Hi everybody, I'm Laurie Cadden and this is the 10th episode of the Lackawanna County Medical Society Public Health Education Series. This one's titled Boomers and Bionics. It's, I think, why we're calling it. We just had this discussion. We're like, okay, why? But the doctors and I were talking earlier, and it's kind of interesting because I asked the question, I said, are boomers having more hip replacements, knee replacements, these type of, you remember that show with Lee Majors, that bionic guy? I always think of these things when you see them, and looking at these make you think about it even more. But these are the things that are being put into our body to help us do better, live longer, and enjoy life because of a damaged hip or knee, which we're going to discuss. So there's a lot of boomers out there now, and as Doctor was saying earlier, they're doing more. They're more active than our parents. We're more active. I'm a boomer at the tail end of it, and I have to point that out. But we're doing more, we're more active, and we need our joints to keep us going and fulfilling all these wonderful dreams and ideas that we have. So we're here to talk about two joints. One is the hip, the other one is it's a joint. So we're here with Dr. Chris Samaj, who will get, No, I just messed up. And Dr. Jack Hensons and Samaj, right? Did I say it? Yay, see, I knew it. See, I was testing him to see if I did. But Chris and Jack, as I may call them right now, are both with Scranton orthopedic specialists in Dixon City. They've been doing this for a while. Chris, a little bit younger, as Doctor was saying. And both of them have a specialty. Chris specializes in the hip, which we're going to discuss. We're going to talk a little bit about that now, get you caught up on if you're having any issues, you want to call these docs or talk to them about it. They're going to show you what happens, and some of the things in the front here are props, which we've been doing now since last time we had Dr. Stopper on. He brought it with the heart. It was really interesting. So thank you for doing that. I think it makes it much more, people can see what it looks like. So Doctor, your education tell everybody about your background, where you went to medical school, and how you have this specialty.
I went to medical school at Drexel in Philadelphia. It used to be called Hahnemann, but now it's Drexel. And then I went to a 5-year training program to do orthopedics, so bone and joint surgery. And then I did a 1-year fellowship, which is an entire year of specialized training just to do joint replacements. So for the first-time joint, and more importantly, for failed joints. So that's why we have different implants here that we use, and some of them are quite big. And you need that extra training to be able to use different parts, customize the surgery, deal with these disaster cases, so that's what I do. Okay.
And so you're in the area how long?
I've been here for about 3 years. Is it 3 years?
Yes,
yeah.
It is.
Yeah, okay.
See?
Just checking.
Yeah. Time flies when you're having fun. So, okay, this is, and we're looking at the hip here. Tell everybody what this is first, and then we'll get into a few questions.
So this is I'm going to pull this up here.
Sure, go right ahead.
Okay, so this, if you focus in here, this is a normal hip joint. So this is the pelvis. The hip is a ball and socket joint. Here's the socket, and here's the ball. And this is your normal joint. Now here is what we call an arthritic joint. See how there's a lot of bone spurs here? The ball and socket, the space between them is pretty narrowed. So that's essentially what we're correcting is hip arthritis. So the way a hip replacement works is we cut the ball off, throw it away, and what you end up is this. So here's the pelvis again, and here's the hip replacement. So we cut the ball out, throw it away, we give you a brand new metallic socket, fits in here, and then we put what's called a stem. Now the stem is attached to the ball, and that's what keeps the ball in position. Give you a new ball, fits into the socket. It's supposed to fit in.
There you
like
go.
That. And it's a frictionless bearing. So basically, this plastic liner and the metal socket, it replaces the cartilage that you've worn away or lost, and it doesn't have any pain, so you don't feel the pain from the arthritis.
Wow. So what are some common, if someone comes to you and says, hey doc, I think I have a hip problem. Or they don't think it's their hip, they think it's their leg or their thigh in many cases, because I think it hurts in the groin area, or it can. So what is the pain they experience, and then what do you recommend if that's what's happening?
So typically, and you know, I see this a lot of time in my office, somebody will come in with hip pain, and they'll point to their lower back, or they'll point to the side of their thigh, which is actually here. That's not the hip joint. The hip joint is always in the groin. So people describe it's deep-seated pain in the groin. They have problems with certain activities, and the number one thing is putting your shoes and socks on. Why? Because you have to bring your thigh up, rotate your foot, and put your shoes and socks on. And they say, well, I can't do it, or I have my wife do it, or I use a grabber, you know.
Wow.
And they feel a lot of grinding inside the groin.
So mistaken thinking it's the hip, because we say these are our hips. So that's why they say that? They feel that this is if they have a pain there.
And that's a different problem. That's bursitis here. And in the back, if it's the butt, it's usually coming from pinched nerves in the spine. So hip joint pain really is mostly in the groin.
And so once you determine that that's it, what would the patient do then after you say, all right, listen, you're having pain?
Correct.
And let's ask this, because I think even my mom, who's an RN, was having groin pain. She didn't associate that pain with the hip. She thought she pulled a muscle or did something else, but it wasn't going away. So when that come in, obviously that's a common symptom.
Sure.
So then what do you recommend? What happens next to a patient once you say, okay, here's what it is? Is it an MRI then, or what happens?
No, typically, I mean, 99% of my diagnosis of arthritis is made with a plain old x-ray.
Oh.
It's cheap, it's easy, it's in our office, takes like a minute to do. But before we even talk about surgery, we talk about some things that people can do to reduce the pain. So probably the biggest thing of all is lose weight. So across this hip joint, if you're just standing there, 2 times your body weight goes across this joint. If you're walking, it's 5 times your body weight. If you're running, it's 10 times. So you can imagine if somebody is 50 or 60 pounds overweight, that's a lot of weight.
Yeah.
I mean, that's like 600 pounds. So number one is to lose weight. Number two, alter your activities. Maybe you can use a cane in the other hand. If you have your left hip is messed up, use a cane in the right hand. It offloads that joint. You can take things like Tylenol, Advil, Aleve, things like that. And you can also try and minimize the things that cause you pain. Like, for example, if you drop something on the floor and need to bend and pick it up, and that's what causes your pain, well, you can get a grabber or something to help you. So there are a couple of things that you can do that does not require any surgery, and probably the most important thing is to lose weight.
And it's funny with my mom, because she lost weight and then the issues happened with her hip. It was bizarre, and that makes sense in anything, because everything is about weight and losing it to help with the joints. But that's the opposite happened, which was really wild. Well, she probably had it to begin with, and but so she did the right thing first, because that is what happened.
Well, and it makes the surgery easier. It cuts down the complications. People that are overweight have a higher incidence of infection, blood clots, things like that. Yeah. So those are things you want to avoid.
So then when if that's the case, so what you're saying is those are things you would do first before, it's not just, oh, let's automatically jump into surgery.
I mean, I almost never sign anyone up for surgery the first time I see them.
So let's make these lifestyle adjustments and see if it helps.
Because these are long-lasting adjustments. These are not just for your surgery. You lose weight, you get on a healthy lifestyle, that's going to carry with you. That's not just for your surgery,
Right. So then, if this is something you would have to get, how long does a hip replacement last?
On average, there are studies out there based on implants that were put in 15, 20 years ago. So we don't really talk about how long it lasts. We talk about what are the odds of it lasting, let's say 20 years. So the odds of it lasting 20 years are 80 to 85%. So that's pretty good. The odds of it lasting 10 years are 90 to 95%. So these last a long time. And with new technology, especially of the plastic, see, the plastic is the limiting factor because it wears away.
Okay.
You know, so with better plastic, I mean, these can potentially last a lot longer than 20 years. We don't know because the technology is changing so quickly.
And it's changing all the time.
And it's changing all the time.
Yeah.
Exactly.
So if someone were then, if that is after they make some changes, they're still having pain, and it's decided between you and the patient to move forward with the hip replacement surgery, what are some of the complications, some of the things that might happen or that you don't want to happen when something like that occurs, when the decision is, okay, we're doing this, here's what we're doing, and you decide on the surgery? What does one have to be careful of and be I guess, totally aware of what they're doing once they decide to do it?
So once somebody decides to have a hip replacement or a knee replacement, the things we're concerned about, for the hip especially, is dislocation, the ball popping out of the socket. And that can be avoided by putting the parts in correctly the first time. You know, so that's one concern. The other big concerns are infection. Okay, that happens less than 1% of the time. It happens less if you're of normal weight. Getting a blood clot in the legs, called DVT, or going up to the lungs, which can be fatal sometimes. And that's pretty low too, but those are some of the big concerns. And
that blood clots are common in any type of surgery, so that's always something that you have to look out for. So when somebody does this and it's done, they have it, everything's going well, what is the recovery time? What can a patient expect that once they have the surgery, the decision's made, you have it, and now they're on the road to recovery? What's their span? I know everyone's a little different, but what would be the expectation of someone having a surgery?
So normally, you know, I tell my patients they're in the hospital for about 2 to 3 days. They go home with a visiting nurse. They're on a walker for 2 weeks, on a cane by 3 weeks, and once they're comfortable with a cane, they can drive. They're back to normal activities by 6 weeks, and if they do sports or anything like that, like, you know, say tennis, for example, usually it's about 8 to 12 weeks. So it kind of builds up gradually, but the recovery can be fairly rapid, and also depending on what approach you use. So I do what's called an anterior approach, which is going to the hip joint via the front, which is what they call muscle sparing. I don't have to split or cut any muscles. So the incision is a little bit smaller. The recovery time is a little bit quicker, especially for a motivated patient. The other way of doing it is going through the back, which is more conventional. You do have to split one of the butt muscles to do that. But again, if done properly, either approach will get you fast results if you're motivated, you do the therapy, etc.
When you say either type of surgery from the front or the back, does it depend on the patient, or are you usually able to go in through the front?
I'm usually able to go in through the front unless they have some sort of deformity or something going on in the hip, where if I really need to see certain parts of the pelvis, I'll do it through the back. If there's something about their anatomy that's funny, then I'll just do it through the back. But generally, I like to go through the front.
And so then is it up to the patient then too for any type of rehabilitation? How does that, do you determine that based on how good they're doing, or what happens with that?
Basically what happens is when somebody comes into the office, we try and get them to do the exercises ahead of time, so that when it comes time to do their surgery, they're already used to doing the exercise and their muscles are already kind of primed. So when they're in the hospital, the physical therapist will make that determination, you know, post-operatively, okay, you know, how fast are you getting up and walking around? Can you get up out of the bed by yourself? You know, they have a checklist of things, and if you're not able to do all of those, then you know, we do have to send you to somewhere like a rehab facility or something like that.
And then that again depends on the patient and how quick they recover.
That's exactly right.
But you're saying, which makes sense, the fact that you're not cutting through muscle, because that, as you said earlier, it's so much harder to heal that. Not harder, but longer, I guess you should say.
It takes a little bit longer. You know, the truth is, at about 3 months to a year, I mean, both groups catch up, the one through the back and the one through the front. The anterior approach gives people perhaps a little bit of an extra edge, you know, for a faster recovery, if that patient is motivated.
So then tell me then, when someone has this and they're, whether it is, and we're talking about boomers, so say now someone's in their mid-50s, late 50s, they have this, they're able then to just resume pretty much what they've done in life afterwards, because as long as they follow, like you said, and do the things they need to do with the exercise, but their life becomes pretty normal again, then minus the pain.
Minus the pain. You know, these are man-made devices. I mean, look at these.
I know, it's amazing.
Giant hunks of metal. You know, you'll always feel that there's
something there.
Something is different about that hip. You know?
Can you feel better almost with it, or is it just?
Most people can tell a difference right away, especially if you have a bad arthritic bone-on-bone joint with a lot of grinding, and then all of a sudden, you know, you have, oh, well, there's no more grinding. I can move my hip a little bit better. You still have the pain from the incision, but that arthritic, deep-seated pain is pretty much gone.
Okay. So the end result with a hip replacement, number one, coming in to see doctor would be you would make sure that you know what you're doing first to the patient, that they know that that's what it is, and that you make sure they make some lifestyle adjustments and see if in fact they can live with that, because surgery is always, I guess, your last option.
It is your last option, but you can make your hip last a whole lot longer if you, again, stick with those lifestyle changes. Stay healthy, keep your weight down, stay active, condition those muscles. I mean, it all plays, you know, it all plays a role in your
And what do you
success.
think about running? What about runners with a hip replacement?
You know, I tell my patients that you should avoid high-impact activities. So if you want to walk on the treadmill, fine. Tennis, fine. Basketball, where there's a lot of jumping up and down, long-distance running, it's really not ideal for the wear of the implant. Okay. So, I mean, if you can avoid that, please do.
Yeah. So is there anything else you'd like to mention before that I maybe didn't cover, or you want to make sure that everybody knows out there?
You know, people in the office ask me, well, you know, how are things different in 2016 versus, you know, 20 years ago or 30 years ago? The surgery is faster, there's less blood loss, you're out of the hospital sooner, the recovery is faster, the parts are better. Back in the 1980s, if you had a total joint replacement, you went to the ICU. You know, now you go to...
That doesn't happen, right.
Now that doesn't happen, you know.
It also helps when you have the training and where you're at with this to know how to do it, because as Dr. Hensons said before, that you want the listening audience, the viewing audience, to know that this is something you specialize in. You're trained in this. You've gotten, you know, all of this extra training and schooling to be able to do that right here in good old Scranton, Pennsylvania, which is a big deal.
That's pretty much all I did for a year, was do total joints.
So. Well, it's wonderful. So anything else before I move over to Dr. Hensons?
I don't think so.
Well, we might bring you back in, so don't leave me, all right? Stay right here. That's Dr. Chris Shamooj, and he is with, again, Scranton Orthopedic Specialist, and we're moving on to Dr. Jack Hensons, who is going to talk about the knee and replacement and all the fun stuff that go along with that joint. And Dr. Hensons, welcome, and could you tell us a little bit about your background?
I went to Jefferson Medical College in Philadelphia, and then to what is now Drexel University, but Hahnemann University Hospital, and did my 5 years of orthopedics there, 2 years of general surgery there first, and then came back and joined Dr. Joseph Caesar and Dr. Chris Metzger in a practice in 1993, so a long time ago.
Yeah, you've been here a while.
And then one of the original members of Scranton Orthopedic Specialists, going back 15 years now. 16 years.
So you came right back after medical school, right back to the area?
Unlike Chris, who did that special year of training, I came right home to work, and slowly have kind of learned you know, a lot of new techniques as time has gone on from people like Chris, who, you know, have had special training. And for me, it was kind of the best scenario, just to come home. Where my family, you know, I grew up here in Peckville, and
went to
worked out
Valley
well for me.
View.
Went to Valley View.
Played football for Valley View. We were trying to get into
some
that
people
before
would
Mark
remember
yelled
that,
at us
so.
about the sunlight outside.
Yes.
So I remember that, because when did you graduate from high school?
1978.
All right, and I graduated in '79 from West. So I remember when we would play, you were were you a quarterback? What was your?
Oh my gosh! See?
See? I remember.
I didn't even pay you to say that.
I know
so.
that. I remember. And so we talk about that old the knee with the football
right.
injury. That
That's
old,
right.
like, that's an old football injury. But yeah, you were very talented. That's good. Now you're talented in this. So here we go. The hits keep on coming. And then you're also learning from this guy who's younger.
Well, I'm
Boy,
learning from
Chris,
him, too.
yeah, I know. That's
Yeah.
how it works. That's how it works. So, Dr. Hensons, we were discussing the knee on the way up in the elevator. So could you kind of tell everybody what your props are today, and then we'll move on to some questions.
Well, this is what the total knee replacement is, and this is 2 out of the 3 parts. There's the kneecap in the front would be missing, but this is the thigh part here, shin part here, and that's made out of, the shin part is 2 parts. It's a plastic surface and then the metal tray. So you have the metal of the thigh part rubbing against the plastic, okay? And you know, a lot of the same things that Chris had mentioned in regards to the preoperative workup and the intraoperative complications and the postoperative stuff is a lot similar for the knee and the hip. There's very similar type of issues that are dealt with. So.
And how about those guys in front
These
of you?
are similar parts. This is how the total knee would sit together.
Okay.
And this is how the knee would bend. When your knee would be out straight, it looked like that. When your knee was flexed, it would look like that. And then the third part again would be the kneecap, which would sit over the top here.
And these in front are just...
These are, this is just trying to show you what the normal surface of the knee is here. Okay, so your knee is not blue inside. This is just colored
Hopefully.
to show you. The knee is, this surface would actually be white inside your knee. Okay, and as you start to get some early arthritis, you'll start to see a little bit of fraying or pitting of the surface. As we get to more significant changes, you'll see some loss of the surface of the bone here. And then the most severe is when it's completely gone. And although this doesn't show too many spurs on the edge of the bone here, you'll start to see extra outgrowth of the bone, and usually some damage then to the ligaments or to the menisci inside your knee.
Okay, so when someone comes into you and says, Dr. Hensons, I have a pain in my knee, or I have something going on, or a football injury, or a tennis, or I twisted it ballroom dancing, or spinning, or whatever the reasons are, they go to you. What do you do to question and to determine what is going on with someone's knee?
Well, I think probably one of the important questions is how long are they having a problem?
Okay.
Because the chronicity will kind of determine where the patients may be in terms of, you know, how soon they need an operation. And probably the most important question is how it affects their life. Okay, can they do the things that they want? Can they do their work? Can they do their housework? Can they do any recreational activities? You know, if all that is significantly affected, then those patients are probably more likely to come to a surgery sooner than later. But as Chris mentioned, you know, a lot of it is, you know, questions to get a sense of where their pain's coming from, examining their knee to get a sense of how stable their knee is, what's their range of motion, checking out other possibilities for knee pain. The hip can cause knee pain. You can have back pain that could cause knee pain. So it's a full orthopedic exam that day. X-rays are then done to determine the amount of degeneration inside the knee. Sometimes the x-rays look pretty good. We need to go to an MRI. An MRI can give us information about the soft tissues inside the knee, the ligaments, the meniscus. It will also tell us about the surface of the bone that we see here, the blue surface, and also gives us an idea of how severe the arthritis is. Once we have all that information, treatment options can be discussed with the patients in terms of conservative care, which can usually be simple things such as medication to try to diminish the pain, activity modification, weight loss key just as much in the knee as the hip. Mm-hmm. The stress across the knee is not as much as the hip, but it is 4 times when you're walking and goes up as you're doing more aggressive activity. But again, the stress across the knee is significant. So that's where when we talk about patients losing even a small amount of weight, you know, 10 pounds turns into 40 pounds off your knees, 50 pounds off your hips.
Wow.
So, and that's what we try to encourage patients. You know, it's hard to tell somebody, hey, I need you to lose 60, 70 pounds. That's very difficult to do. Mm-hmm. But we can get them to, you know, change their diets a little bit, change their activities a little bit, And if they can burn off a few calories, lose a little bit of weight, they usually feel good about themselves. Their knee pain usually gets a little bit better, and sometimes that can spur them on to continuing to lose weight. Others can't seem to get the pain to go away with the simple treatments, so then we go to something a little more aggressive, maybe a brace. Can sometimes give people some support while they're walking. We may start patients in physical therapy to strengthen their muscles, especially their quadriceps muscles. The stronger we make those muscles, the less stress goes to the knee joint. That also helps patients burn some calories as well when they're in therapy, because there's usually a aerobic part of it as well, maybe riding a stationary bike, which helps them burn some calories. So if those treatments don't seem to improve, there are injections that we can do in the knee that give people a lot of relief, the most common being the cortisone injection or steroid injection. Cortisone is generally not a drug used much anymore because it's too short acting. We use other drugs that are longer acting. But those steroid injections can be very helpful to, sort of control the pain.
Where do they go? Where does it actually go? Right into the muscle or the
right
knee?
into the knee joint. You would inject it, usually either if you go from the side, it would go underneath the kneecap. If you go from the front, it would go into the front of the knee. And the fluid that is with it would circulate throughout your knee and sort of diminish the inflammation that's in your knee, and most patients generally feel better, and some feel better for months and months, others less time.
So that's an alternative then to going into, as we talked earlier. Let's try to see what else might work before we do surgery in any way. Let's make all these other changes.
Yeah, most patients, as Chris mentioned, most people aren't coming in to sign up for surgery. Although you will meet people who have been treated by their family doctor or just realize they've put this off for a long time and their life is compromised, and now they're ready to go. And most people, I would say, are not. They're they want to try conservative measures first. They want to avoid the surgery if the best they can, because it does come with risk. These are not risk-free procedures. So patients generally, we try to do all these conservative measures first and see how they do. And if that fails, the patients again have to come back to that concept of, how does this affect my life? Can I do the things I want to do? If they're boomers and they want to be active, maybe it affects their ability to play tennis or play golf. Hopefully most of the boomers are not playing contact running sports anymore. They're not playing. But we will meet
those diehards.
We will meet those patients.
Wait, you mean you don't play football anymore? Not even flag or something?
No. Well, I'd love to, but I got to go to work every day.
Chris, watch them really. You better be careful.
So my children depend on me getting to work every day so they can live their life that they like. But most of those patients aren't playing high-level contact cutting sports, but they want to play golf. They want to be able to get through work every day without pain. They want to be able to go for a walk with their wife. They want to be able to walk on vacation. They want to dance at a wedding, as you mentioned, or if they're doing spin classes or whatever recreational activity they do. When that's affected, then patients realize, hey, I can't go on like this. I need to do something about it.
Right. So is a good exercise for, as you were saying about if they're in a therapy a little bit beforehand, is a good exercise for the knee with an issue prior to doing any type of surgery? Is a stationary bike good because you're obviously sitting, so that's less impact on the knee while you're exercising? I'm assuming that's why that works.
It is.
For that one.
It is.
And yet you still get the aerobic benefit.
You do. You get that aerobic benefit, and you get, depending on which type of bike, if you're in an upright bike, you're getting a little bit of core training because you have to hold yourself up. If you're in a recumbent because you have a bad back, you may not
You might have a
burn as
bad
many.
bike too.
Yeah, right. But even just simple squatting exercises are probably the simplest thing people can do at home. Cost them no money. They don't have to buy any equipment, and just a simple squatting exercise will give you tremendous strength in your legs and help to try to diminish that pain.
So what other type of procedures can be done? You said there's the injection of, as you said, cortisone, which it really isn't called anymore because you said that's not as long acting, so it's some type of steroid that's injected. What other things are done in lieu, or is that about, other than the lifestyle changes we talked about, are there any other type of a brace, anything else that we missed that could go before you take that last step of surgery?
Well, if your MRI shows that you have some torn meniscus, or what people refer to as cartilage in their knee, sometimes if your arthritis is not severe and you can remove menisci that are sort of getting caught inside your knee, you may be able to diminish some of the mechanical symptoms that they describe. There are other type of injections too. There's some lubricant injections which have, some relief for some patients, not for everybody, depending on the amount of arthritis. Some of the newer treatments are actually injecting some of your blood products into your knee. Again, not great long-term research, but for some people, that seems to help them. Even stem cells has been tried. Wow. To try to repair the worn out cartilage. That probably works best in patients with mild to moderate, not severe. Those are expensive treatments, but for some people that's a way of trying to avoid the inevitable, which is an operation and getting cut. Mm-hmm. But for the people who then, again, can't live the life the way they want, they're struggling with pain, their activity level is really diminished, and they've tried the conservative measures, they've tried therapy, they've tried the brace, they've tried medicine, and they're still miserable, then surgery to replace their knee is the answer. Mm-hmm. And there are a couple different type of knee arthroplasties to do. For some younger patients who have isolated knee arthritis, you may be able to do a partial knee replacement.
That's what I was just going to ask about partial replacement.
And some of those patients may have significant arthritis around their kneecap, so there is a kneecap replacement procedure.
There is?
Called a femoral arthroplasty. You could have just one half of your knee, which is probably the most common partial knee replacement or unicompartmental knee arthroplasty. Generally, the medial side of your knee, the inside part of your knee, is the most common, and that's
Why?
I think it's probably just the alignment of your legs. Okay. More people seem to get wearing on the inner half of the knee than they do on the outer half of the knee. And that's a very successful operation done in the right patient. Generally, thinner patients, activity level a little bit less, and generally the best studies have been in older patients who do it. But there are some younger patients who can do it and get away with, and then hopefully avoid that full knee replacement for 10, 15, maybe even 20 years if they're lucky enough. But again, you got to have a good knee, you have to have good ligaments inside your knee, and it has to be isolated to just one compartment.
And uncompartmental knee replacement means what?
Unicompartmental?
I'm sorry,
just
I'm reading
one out of the
glasses.
three compartments. Your three compartments would be like I'll do it on the model here, your medial compartment, your lateral compartment, or the patellofemoral compartment. So if you have just isolated knee pain in one of those areas, then you can, and your knee is otherwise relatively normal, ligaments are normal, no history of sports injuries where you've torn ligaments, and no complaints of pain on the outer half of your knee or around your kneecap, those patients may do well with the partial knee replacement. And
what about a patient who, and I know they do this because I have a friend who just had it done about a year ago, knee replacements on both knees are affected, both legs. So are they done at the same time?
Yes, bilateral knee replacement can be done. It's a very effective procedure and successful procedure on patients that have two bad knees, that once you fix the one knee, they're still not going to be any better because the other knee will still be sore and painful, and they'll still struggle with their routine activities at home, activities at work. So those patients, if they're healthy enough, you have to be healthy to do that because it is a lot of stress on your body, stress on your heart, stress on your lungs, and you do take some risk. There's a little bit higher risk. Obviously, you're going to bleed from both knees, so you have a higher risk of maybe getting a blood transfusion. Although some of the techniques, as Chris mentioned, that we do today diminish that blood loss. But the patients, if they're really healthy, they'll do well with both knees. And I've never met a patient who had both knees done that regretted that they did both. But I have a lot of patients who only do one at a time and then regret that they got to come back and do the second knee.
Because they know what to expect
now,
right?
Because now they're going to have to go through that whole process
again. It's no fear of the
again.
unknown. They know.
Right. And patients say, oh, well, how am I going to walk? Well, they do. They get up and walk that day. And their pain is there. They'll have pain in each knee, but it's not twice as much pain, I don't think. And they function well. And 6, 8, 12 weeks later, when they're done with both knees, they're the happiest patients because now they're done. They don't have to come back in 3 to 6 months to do the other knee. Their family's happy they don't have to come back because the family's life's not altered by the fact that they're going to the hospital. So if you're a candidate for a bilateral knee replacement and you're healthy enough to do it, it's a good thing to do. Yes,
now,
we do.
Why is it that one is injured and the other one wasn't? Is it because you're compensating for the problem on the other knee that the other one's affected, or is it biological, or what is it?
I would probably think it's more genetic, like we'll blame our parents for the genes we got. Now, you could have injuries in both knees and through sports injuries and end up with both knees being worn out. And I guess if one knee was injured early in life and now the other knee slowly deteriorated, you could have that. But I think in general, I would say it's probably more genetics than anything else. Would you agree with that? Yeah, I think so.
Yeah. And because as we were teasing before, we were saying the hip bone's connected to the thigh bone. So If someone who has a hip issue or a knee issue, are they related? Like, if you're having a problem with your knee, can your hip then be affected, or the opposite, or no? Or doesn't that have anything to do? Am I just making it?
No, I agree. I think in what we see, I think you'd probably agree, is that a person will have a bad right knee and then a bad left hip, and depending on which came first, they've tried to unload to the other side, and now that other side becomes affected. And that would probably be one of the more common combinations that we see, as opposed to, say, a bad right knee, a bad right hip. I would say we see a bad right knee and a bad left hip.
So then when someone has this, as I asked Doctor earlier, what is the recovery time for this? How can they get right back into doing? What do you say to someone who has a knee replacement or a partial knee replacement? What is their protocol as far as getting back to normal activities?
Well, for the knee, I would tell you, I think it takes a little bit longer to fully recover. I think the patients who have their hip replaced, they usually wait till it's really late. And when they get that hip replaced, the next day they'll tell you the pain that they had before the surgery is gone.
Yeah.
And they have a different type of pain where the muscle was split, and I do the posterior approach, Chris does the anterior approach, one of the few people to do that. And they will have almost instant pain relief. They'll tell you the next day. Now, the knee replacement patients don't feel that great. Their knee is sore because muscles that are in the front of your leg are again split, or you can try to elevate them off if they're thin enough to expose the knee. But the recovery from the knee replacement is dramatically harder on the patient than it is for the hip replacement. Plus, your knee does not want to bend because the muscles have been irritated by the surgery, and that's the hardest part initially for the recovery. For me, I would generally tell most patients it's about 3 months recovery. Now they're in the hospital 2 days, just like the hip, 2 to 3 days. Some patients struggle and don't have good support at home, and they need to go to rehab.
Right.
Most patients, if they have good support at home, can go home, and if they're young enough and can take care of themselves and they don't have to go up and down too many steps initially, they can generally go home with the therapist and a nurse going out to their house and working with them. And the recovery, they can drive within a week or two if it's the opposite leg. If it's the leg that's been operated on, maybe it's about 4 weeks. You got to have good, reaction skills to get your foot from the gas to the brake, and sometimes that takes a little bit of time. And then for me, I would say, some patients can start doing some, non-impact sports activities like golf. Maybe you could do that at 6 to 8 weeks. The running, tennis activity would be, more about 3 months, I would think, for the knee.
And do you see a lot of issues with that, with the joint of the knee from running?
Again, I think it's genetics. We have patients who are marathon runners in their 70s and their 80s, and God bless them with fantastic articular cartilage that holds up over time.
It's amazing.
It is. And then others patients who, you see people in their 30s and 40s with severely arthritic joints, and you think, like, what happened to them? And it has to be a genetic thing, unless they had trauma. They had a sports injury in high school or college, and maybe then they, that knee deteriorated quickly because of that. So.
All right. Anything else about the knee that I didn't ask you that you might want to talk about?
I will tell you that patients, when their pain is gone, they're so grateful that they have their quality of life back. And we see this for both the hip and the knee. There are patients who aren't totally happy because things can go wrong. The same risks are involved in the knee in terms of an infection, which is low, less than 1%, blood clots, which is a little bit higher, although generally not enough to create a big problem. We don't have the risk of dislocation that the hip does, and the knee patients they're thrilled when their pain's gone and they could
do their old stuff.
For women, it's shopping and and working, and for men, it's being able to work without pain, or to play golf, or just walk on vacation and not have a sore knee, and run with your grandchildren, and do simple things in life that you take for granted. Getting in and out of the car, terrible thing when you have a bad hip. Going up and down the stairs in your house, getting out of a chair, not wanting to go out to dinner because if you sit too long, you'll be too stiff and everyone looks at you while you're standing there trying to loosen up. So, those patients, once their joint is replaced and they're recovered, they're so happy, and patients tell us all the time how they got their life back. And that's what makes it.
Which is really the end result that you guys feel so good about being able to do that for somebody.
Absolutely,
That,
yeah.
hey, we, you know, that they become bionic men and women after you guys are done with them. So
Right,
it's,
Steve
it's all
Austin,
good.
$6 million man.
That's what it was, exactly.
He was too young. He wouldn't have
Lee
known that.
Major,
Yeah.
though, he was the star, right?
Yes, he was.
There you go.
So you remember Lee
I
Major?
do, because he was married to Farrah Fawcett, wasn't he?
Yes, Farrah
Yeah,
Fawcett.
for a while. See, you
I do
know who
remember
she
Farrah
is. There, of
Fawcett,
course
yeah,
you do.
of course.
There we go. Well, thank you, gentlemen. This was
Oh, you're welcome.
very informative. I love it. And the fact that, one question, the reason that that can dislocate is because of that ball type insertion. Is that why? Because it's not the same there, and that's why you said it's not as, that is, you said that was something that could occur.
It may happen.
Is it just because of it's round, it's the ball effect that it could slip out, where that one wouldn't?
You know, it has to do with the way the pelvis is shaped, the orientation of the leg, and the fact that it is a ball and socket joint. It's got less sort of conformity, if you will, than the knee, you know, so it can happen, but it's fairly rare, thank goodness.
I know. Well, and you're doing it, it's all good, right?
Cross your
There you
fingers.
go. Okay.
Yeah, and as you mentioned, the conformity of the knee, like the knee is inherently stable with ligaments on the side. There are some knee replacements that save the ligaments inside the knee. The most common removes the ligaments inside the knee, the ACL and the PCL, but there are ligaments that the PCL can be saved in, and even newer prostheses that tries to save both ligaments that try to give you a more natural feeling knee.
So you just attach that, or what's
Well, you know, one of the misconceptions, you know, Chris explained how the hip is done, and one of the most common things people ask me is, well, you know, they chopped my knee off, right? Like my knee's gone.
Yeah, right.
And it's not. You know, we don't chop here and then put parts
whole
in.
new
You know,
piece.
in general,
Right.
that can happen if there's tumors or, you know, bad infections or, you know, patients who have had to have multiple surgeries. But in general, you know, we just remove just the very small surface of the bone. You know, maybe 8 to 10 millimeters at most on each side of the knee, the thigh bone and the shin bone. So we're not, you know, we're just essentially replacing the surface with the metal and plastic, and they're inherently stable together as long as the ligaments on the side are good, based on how the plastic has this little dishing in it and this little post that you see here. Okay, and that kind of gives the knee stability so that it doesn't dislocate. Okay.
There we go.
Yeah.
Okay.
Yeah, there
Well,
we go.
thank you for joining us tonight, taking time out of your busy schedules to be here. We appreciate it, and it was a nice conversation.
Thank you
Well,
for having
thanks
us.
for having
So
us.
keep up with all your good work and all your continued, do you keep doing this over and over with being trained further on these hip replacements?
Yeah, it's like a
have
golf
to,
game,
right?
you know?
Yeah.
The more you do, the better you get,
I see.
theoretically.
I know.
I'm not a
Golf.
good golfer.
Yeah, nice. Yeah. Well, that's okay. All right, so
As long
thank
as
you.
you're a good surgeon, that's what we're
That's what matters.
that's what
And right
counts.
here,
That's
that's
what
what
we need to
matters. Well, we'd like to thank you for watching. Again, this was the 10th episode of the Lackawanna County Medical Society's Public Health Education Series, and we had the wonderful explanation of the knee and what you can do prior to making a decision to have surgery, and then if not, surgery is there, and Dr. Hensons is happy to do that, and that's Dr. Jack Hensons. Jack Hensons. I gave you a new name now,
Thank
too,
you.
Jack. And then we also had talked about the hip and the replacement, or the things you can do to not have to go in that direction. But if you do, Dr. Chris, I'm going to say it. Say it to me. Samooj. I love it.
Yeah, there we
So
go.
thanks. And we'll see you guys soon. Next time, we have women's health technologies as our next topic. So we'll stay tuned for that one. And we'll see you again, everybody. Thanks for watching. I'm Laurie Cadden.